Bismillahirrahmanirrahim. We are going to start our this first SOGP webinar on this prevention of the cancer of the cervix with the name of the Allah and with the few verses of the Holy Quran. Bismillahirrahmanirrahim. Qul huwallahu ahad Allahu samad lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahul azim. Okay. So they're all SOGP members and the senior members and all the viewers, healthcare providers, and all the panelists, speakers, journalists, pediatricians, and all those who are joining us today in this webinar. On behalf of SOGP, it is a great privilege and honor for me to welcome you all today in this very important webinar, that is the prevention of the carcinoma of the cervix. As we all know that the CA cervix is the second commonest malignant tumor of the women and the third commonest cause of the cancer deaths in all over the world. In Pakistan, usually CA cervix is the leading cause of the cancer of the female genital tract. But good thing is that it is a long precancerous period. If we can detect pre-malignant condition of the cervix, then we can prevent it. But due to the lack of awareness, socio-economic status, socio-cultural, and lack of awareness, it is not preventable. So majority of the women usually come in the late stage of the CA cervix. So today's webinar is really on the prevention of the carcinoma of the cervix. SOGP is every year organized this seminar in the month of the January every year. And I am very thankful to Dr. Sadia, who is organizing all this. And every year we are talking about the prevention of the CA cervix, how to prevent, about the vaccination, screening programs, and everything we have to give the awareness. And as all of you know that SOGP usually conduct the workshops on colposcopy, visual inspection of the cervix, pap smear, and the preventive measures to take the preventive measures. So all this every year we are talking on this. So today's is also we will discuss on this. There are a lot of the panelists, experienced gynecologists, persons, pediatricians, journalists. So I am thankful to all of these who are joining today this very important webinar. And I am also thankful to SAMI Pharmaceutical Company who have supporting us for organizing this webinar. And especially thanks to Dr. Sadia and Dr. Haleema Yasmin, who is the very active organizers who are conducting this. So I hope every one of our members will get benefit from today's discussion. Thank you so much. Sadia, ठीक है?
Thank you, Dr. Razia.
अब मैं डॉक्टर अब हलीमा को कहते हैं कि हलीमा करे कुछ.
Dr. Razia, thank you very much for your welcome remarks and opening the session, the very important webinar. So it will start with the key talk for cervical cancer, survivor speech, and also HPV vaccination for primary prevention. For this, I'll hand over the podium now to Dr. Sadia.
Thank you, Professor Haleema. We have been talking about this every year, and this year we are doing this as a webinar because of the COVID, and it has brought us all together. And the last webinar, the last seminar we did on this topic was a couple of years back, in which we had a cervical cancer survivor come and address the audience. So we will start this program with a video that she agreed to make. And in fact, she and her whole family wanted it to be shared wherever in the social media or wherever in our meetings, so that other women can be prevented from facing So we will begin by watching this video.
जो कि मुझे लगा कि बहुत सीरियस बात है और इससे पहले कि मेरा थोड़ा सा प्रॉब्लम चल रहा था, इसके लिए मैं हर साल मैंने एक दफ़ा तो जाती थी, लेकिन एक से ज़्यादा भी मेरे विजिट मेरी गायनेकोलॉजिस्ट के पास होते थे। तो मेरे दिल में था कि कहीं कोई चीज़ मुझे कोई चीज़ की जो इतनी लंबी बार बार हो रही हो, उसके लिए मेरे दिल में डर खुद से मौजूद था। तो बस पर मैंने उसके ऊपर मेरी उस वक्त पर मैंने एक्शन लिया और डॉक्टर के पास गई और मेरी हिस्टेरेक्टमी हुई और मेरी कीमोथेरेपी जो भी कॉन्करेंट ट्रीटमेंट था वो मुझे मिला और अल्हम्दुलिल्लाह अभी मैं ठीक हूँ।
सॉरी मैडम सादिया, आपकी साउंड नहीं आ रही, पिक्चर तो आ रही है लेकिन साउंड नहीं आ रहा।
Okay, I somehow lost that video, so I'll have to find it again. And in the meantime, I think we'll do the presentation first, and then we will watch the video. So many people in our panel and our people who are attending this webinar would be aware or maybe not be aware that WHO has called for elimination of cervical cancer as a public health problem through intensified vaccination against HPV and screening and treatment. Now, in August 2020, the 73rd World Health Assembly passed this resolution, and this was a historic announcement by officially launching the elimination strategy. And the goal set for all countries, and which includes Pakistan, is that 90% HPV vaccination coverage, 70% screening coverage, and 90% access to treatment by the year 2030 should be achieved by all countries of the world. So breast cancer is the leading cancer in the whole world. And we have cervix uteri coming at number 4 after breast, colorectum, lung, and then this comes at number 4. However, after breast and oral, we have cervical cancer. So Pakistan is one of the 10 countries with the highest death count. It comes number 7 from cervical cancer. So not just the incidence, but the highest death rates is in lower income countries, and we are one of them. So what are the signs and symptoms? It is a silent killer. That is the thing about cervical cancer, that it doesn't usually present with any symptoms until it's too late or it has started spreading. So it can cause abnormal bleeding between periods with intercourse, after menopause, unusual vaginal discharge, leg pain, pelvic pain, and bleeding from the rectum or the bladder in very advanced stages. So not only is it a silent killer, it kills women in the prime of their lives. They're usually younger women. And I will just for real women, because you see, we gynecologists see these women because it's like a taboo disease. Women don't talk about it. Usually it's us gynecologists, radiation oncologists, or family physicians who tend to deal with these women. Now, the first one is, you can see her photograph, and I've deliberately shared it with her husband's permission. Again, her family was devastated by her death, and her husband actually came to our last meeting to address 6-year-old, married for 4 years and getting fertility treatment for 2 years. Nobody did a pap smear, and she presented in emergency with acute pelvic pain. And when investigated, she was labeled as PID, acute PID, and on antibiotics, and on investigation, she had stage 4 cervical cancer and a frozen pelvis and cannonball mets in her chest x-ray. She died within, I think, 6 to 8 months. The second one is a patient who was referred to me. She was 32 years old, second gravid. She'd had 2 children. It was her second marriage. She had CIN3 on a routine pap smear. We did a loop excision, but then on follow-up a year later, she had recurrent CIN3. And as she had completed her family, decided to undergo a total abdominal hysterectomy rather than further screening and monitoring. And she's alive today. So it is such a simple thing that can, simple preventive measures can be taken, and lives can be saved. So this is the message we want to give, that not many cancers are preventable. However, cervical cancer is. One of the simple things that we say for most cancers is, like do not smoke. Pan, gutka, tobacco, all these things are bad for any cancer and a risk for any cancer, including cervical cancer. However, specific to cervical cancer is safe sex and the use of condoms, even if a woman is using other contraception, but like the hormonal contraception or IUD, condoms still protect against infections and reduce the number of rife in Pakistan. If you go through the PDHS, 4% of couples in Pakistan, that includes men and women, are in a polygamous relationship, which actually means multiple sexual partners. And of course, all kinds of, we're human like the rest of the world, and all kinds of human behavior, relates to us as well. So extramarital affairs, everything goes on in Pakistan. The other worrisome thing that happens in Pakistan is early marriage, and marriage sometimes happens even before puberty. So that is very dangerous as far as cervical cancer development is concerned, because the immature cervix and the transformation zone where cervical cancer starts is very susceptible to infection, HPV infection, and cancer development. So, but once a woman becomes sexually active or gets married, regular pap smears or HPV screening should be started. And till recently, I mean, in Pakistan, this hasn't really taken off, even though the vaccine has been available, is to get vaccinated. And so previously, this was something which was conceivable, that you can prevent a cancer by vaccination. But here we have one cancer which can be prevented. So there are 3 phases of prevention of most diseases. especially infectious diseases. The first is the primary prevention, where you take measures to stop the disease before exposure. So that is vaccination. This is where vaccination comes in. Secondary prevention is once you have the infection and there is disease onset, you should be able to detect early. Then you have the preclinical stage. This is the preclinical stage where early detection can still save her life and expensive treatment can be avoided. Tertiary this is where most women in Pakistan present to us, where the signs and symptoms set in, because remember I said it's a silent killer. And once the signs and symptoms are there, they may come to a doctor. The rich ones or the ones who can afford it can go to a doctor or a medical facility. If they are early, they may be cured or live with disability, fistulas, etc., and have a very, very painful death. So this is the sad thing. And the sad thing is when they come in stage 3, or stage 4, they have the poor ones have or whatever animals to get the treatment done for their wife or mother. So it's a very, very sad situation. So as I said, HPV vaccination is a ray of hope for us, where before they get married, they should get, I said, it can be done with HPV screening. This is available in Pakistan. There is cervical cytology or pap smears. Again, both pap smear on the slide and liquid-based cytology is available in Pakistan. Then we have an alternative visual inspection with acetic acid. And this is a very good option and cheaper option for Pakistan, where screening is concerned, where they may not be available the services for a cytologist. And colposcopy and local excision of the lesions, early lesions, if we can find, like LEAP, LETS, cryotherapy, knife cone biopsy, and hysterectomy. These are all the later sort of treatment options. So these are the high risk factors: low socioeconomic economic group, smoking, number of pregnancies, early marriage, like I said, prevalence of infection, number of sexual partners, polygamy in Muslims. Low risk factor groups are the, like Muslims are supposed to be, and Jews, and circumcision is supposed to protect. However, like I said, religion doesn't come into this, because the human behavior is the same all over the world. So the acquisition of this virus is through sexual intercourse, and 50 to 80% of women will acquire this infection. Those infections will be oncogenic type of HPV. Now, HPV, there are more than 100 types of HPV subtypes. So the risk starts from sexual debut and continues through life. It doesn't stop. This is the Hpv cycle. As you can see, this is the virus. It enters through the mature. If there are breaks in the squamous epithelium, it enters through that, and it travels down and basically infects the basal layer. And then as it divides, it goes into the top layers, and they may be released into the secretions of the cervix and vagina. And this virus is actually quite clever. It just infects the epithelium. The life cycle occurs entirely in the epithelium of the cervix. There is no viremia, there is no cell death, there is no inflammation, and it causes local immunosuppression by its own viral proteins. So it actually dodges the host immune system very effectively. Hence, women do not develop antibodies to this. So there's no immunity as such. So you can get infection and reinfection. Now, as I said, there are more than 100 types of this, and there is and they are kind of related to each other. So the green and the yellow dots actually have the oncogenic ones in them. HPV 16 is closely related to HPV 31 and 35, 52, 33, 58. These are all oncogenic. So if you immunize against 16 or 18, you're actually getting cross immunity to the other types as well. So there is added protection. Now the vaccines which are available they're not available in Pakistan right now. We had the bivalent and we had the quadrivalent available till recently, but now they are not in the market anymore. Nonavalent vaccine, which is the latest vaccine, by latest I mean it's been around for more than 5 years in Western countries or developed countries. It is being used, and it is the best vaccine at the moment because it addresses addresses 9 strains of the oncogenic HPV virus. How do we give the vaccination? This is actually included in the school health programs of most developed countries, including our neighboring Muslim countries like UAE, Saudi Arabia, and most developed countries. So Pakistan and Afghanistan and India, I'm not sure about that, but maybe Bangladesh also. We are one of the few countries which still have not implemented or added this to our EPI schedules, which it should be. So the simplest is to vaccinate girls at between the age of 9 to 14 years, right? And when you do that, this would be around the time when they're leaving school, then you just need 2 doses, 0 and 6 months. Good antibody levels. And so far, the other vaccines, the bivalent and quadrivalent, which were available in Pakistan till recently, they've been around for more than 20 years. And many of myself and many of my gynae colleagues who are aware of this vaccine have even vaccinated our daughters, our nieces, or our doctors who work with us. And the aim is to vaccinate before marriage. However, if you are going to vaccinate after 15 years, then you need 3 doses. So it is cost effective, and 3 doses like the Hep B vaccine at 0, 2, and 6 months. So it's more cost effective to vaccinate them before 14 years. And what shall I say? So far, there is even talk that we may just need 1 shot. The immunity antibody levels are so good 20 or 25 years down the line with just these 2, bivalent and quadrivalent, that we might have even better antibody levels and may not need booster doses at all. So as I said, if given the choice, right now, as the vaccine is out of the market in Pakistan, the nonavalent or 9-valent vaccine is the one of choice for us. Even 1 dose of the vaccine may be enough to help lower the incidence of cervical cancer, and there's ongoing research on that. This will, of course, save us a lot of money. Secondly, with pap smears, and we must keep in mind that HPV vaccination does not eliminate the need for screening and pap smears later in life for disease caused by other oncogenic HPV viruses. What happens? I mean, just because this is such a common, remember this is the wart virus, the common warts which we see so frequently. Not everyone who has warts is going to, or who gets HPV infection is going to get cervical cancer. 1/3, even if they develop CIN, cervical intraepithelial neoplasia, 1/3 will revert to normal. While if they have CIN invasion in 10 to 20 years, it doesn't happen very onset disease, which takes a lot to pick up the intraepithelial neoplasia before it starts becoming invasive cancer. You have a lot of time. So if you're doing screening, you can save so many of these women. So the value of screening is that abnormal pre-cancer cell changes found during screening can be monitored and, if necessary, treated before they progress to cervical cancer. The risk of developing cervical cancer is 3 to 10 times greater in women who are not regularly screened. So this is what liquid-based cytology or VIA can be done if you don't have facilities for pap smear or liquid-based cytology, or you can do visual inspection with acetic acid. And I will try and show a video of that a little later. So you can start, different countries have different protocols. You can start at 20 to 25 years, every 3 to 5 years, and stop at 65 years if a woman has had no abnormal pap smears. It is done yearly in the USA for insured women. The ones who are not insured are like Pakistani women, I guess. And it's every 2 to 3 years in Iceland, every 5 years in Finland. WHO is also talking about self-care, and so the HPV test can also be done as part of self-care for women who are unable to come to a doctor or visit. The same liquid-based cytology medium can be used, and like a swab test can be done by, these kits are now commercially available, and women can test themselves at home. It's like just like inserting a caniston or like a pessary inside the vagina, and women can easily be taught to do this themselves. Now, visual inspection with acetic acid is again very easy, and we're going to be holding trainings for our gynecologists and nurses and midwives for this. And this is basically, you do a per speculum examination. You see, say, an ectropion or a lesion. This is a CIN2 or 3, and to naked eye without any acetic acid, this is what it looks like, a pinkish dotted lesion. And when we apply acetic acid, which is basically household vinegar, which we use for cooking, it can be used because it's around 4 to 5%, the strength of it, and easy to do, or you can get a pharmacy to prepare the solution for you. When we apply it, within a minute or less than a minute, or abnormal cervix, they stain dense aceto. It's called aceto white because it becomes very easy. It can be seen with the naked eye. You don't need a colposcope to visualize this. So a trained nurse or a doctor can do this, and if they find these changes, this patient can be referred to a colposcopist or a consultant gynecologist to excise this lesion and manage the case. So what are we going to do when we are when we find abnormal cytology? So there's correlation between dyskaryosis and CIN grade in only 70%. Not all of them are going to be confirmed CIN. If it's an inadequate smear, you repeat it. If it's a negative smear, you repeat it in 3 to 5 years. You are reassured, but you still need to repeat it. If it's borderline, you repeat and refer to a specialist. If there is mild dyskaryosis, which is equivalent to LSIL or CIN1, you repeat and refer. If there's moderate dyskaryosis, which is equivalent to CIN2 or high-grade squamous intraepithelial lesion, you refer for colposcopy. Similarly, for severe dyskaryosis, urgent colposcopy. If there is any hint of invasion, urgent colposcopy. If there are glandular cells, you must think of glandular intraepithelial neoplasia, which has a worse prognosis. She needs urgent colposcopy, hysteroscopy, and DNC. The treatment options for CIN are, well, no treatment. You can just follow up for mild change. You can just, if you think she's reliable and will come for follow-up, you can do that. But in our setup, I think it takes a lot of courage to do nothing. So you can do local diathermy, cryotherapy, laser. Well, laser is basically out now. These diathermy loops have made the treatment so easy outpatient that we don't use the laser anymore. And knife cone biopsy, of course, if you don't have this, then that's our gold standard, which was used before. However, it causes a lot of morbidity and has complications. And of course, last resort is hysterectomy if you can't, if she's completed. It's very expensive for invasive cancer. Radical hysterectomy, radiotherapy, combined chemotherapy, all these things are very expensive in tertiary care hospitals, and we have our panelists and we'll be talking to them what problems these women go through when they have this. Now we formed this Teal Ribble Alliance in 5 years back in January 2015, and some of our panelists are here. We have Professor Razia Korejo, who's the president of our society, and Dr. Rosila is here from Ahsan, and Dr. Akbar is, he was general secretary of the Pakistan Pediatric Association then, and PPA, and so we did this, and AMAN and SOGP joined hands, of course. But you see, it's like only we are talking about it, and very few others are concerned about it, and the public, and I think the government is not really listening to us. So SOGP actually has come up with a guideline for primary prevention, and these are on our website as well now, that HPV vaccination should be added to the EPI schedule. This is what we're asking for. Pediatricians should add the HPV vaccination to the list of vaccines administered on the child. They should further advise those girls, because you see, there's a gap when a child becomes a teenager. They kind of lost, you know, between the pediatrician has given up on them, has done their bit, and by the time they become adults and they want to, you know, they want to come to a gynecologist for advice, sometimes it's too late to give them a lot of health advice. So the pediatricians should have it on the card and must ensure that they get this vaccine between 9 to 14 years. And of course, now even the Supreme Court has premarital consultation, and this should be with a gynecologist or family physician, and who should also be promoting this so that she gets health and contraceptive advice and HPV vaccination before marriage to get the maximum benefit. So regular pap smears, liquid-based cytology can be used, or the routine traditional pap smear with HPV testing. Screening should start after 3 to 5 years of marriage at 3 to 5 year intervals. And VIA training should be mandatory now in our training programs. By the age of 30 years, at least one pap smear or LBC HPV test should be done. And we can stop pap smears at the age of 65 years if the previous ones have been normal. We must all create awareness among general gynecologists, pediatricians, general physicians, family physicians, women, and general public. And the stigma poses significant barriers to the prevention. College and the Advisory Committee on Immunization has given similar recommendations. And in addition, I just want to add that HPV vaccination should be delayed until after pregnancy. However, many pregnant women have been inadvertently vaccinated during pregnancy with the HPV vaccine with no harmful effects either to the mother or baby. So right now it is not recommended during pregnancy, but poses no harm. And breastfeeding mothers can receive the HPV vaccine. There's no problem with that. So that should happen. More recent upcoming evidence has shown that HPV vaccination is 5 to 50 years who are DNA negative at vaccination. HPV vaccination is equally effective in women that are HPV seropositive at vaccination, and vaccinated women show reduced recurrence rates after colonization. So even when they go through the LEDS treatment, I mean, I'm also vaccinating. Until we had the vaccine here, I was still vaccinating them. Vaccination safety is endorsed by all international and national review boards. So in summary, HPV type 16 and 18 cause 70% of cervical cancer globally. The nonavalent HPV vaccine protects against 9 strains. Phase 3 clinical studies have demonstrated high efficacy, more than 90% protection, and including vulvar and vaginal precancers and anal cancers. The vaccine efficacy and antibody response are found to persist for at least 5 years with the nonavalent vaccine. However, the other ones, they've been around for over 25 years now, and the no booster dose is recommended so far. And 93% of cervical cancer and anogenital cancer can be prevented by the nanovalent vaccine. So what is the impact in countries with established screening programs? HPV vaccination plus screening is predicted to be more effective and cost effective than just screening alone, and screening should continue in order to detect disease related to non-vaccinated HPV types, and screening intervals are likely to increase once widespread vaccination occurs. In countries without existing screening programs like Pakistan, vaccination is likely to be the most effective option to reduce the incidence of cervical cancer. So high antibody titers can be sustained for decades, and a single dose may be enough. Long-term efficacy studies are awaited, and loop excision with the colposcopy younger women and still get treated, hysterectomy for women who do not want other children, and vaccination and screening is the most effective to reduce the cervical cancer. Now, before I went into this vaccination, I mean, to me, it was a new thing that you can prevent a cancer by vaccination. When I started working on cervical cancer vaccination nearly more than 15 years back. But there are many cancers which are protected with vaccination. Not cervix is one of the most effective, and you get protection against stomach, liver, upper throat, nose and mouth. You know, the Hep B vaccination protects you against liver cancer, and most of us don't know that. So a lot of these cancers can be prevented through one or the other vaccination. But most Pakistani women cannot afford expensive vaccines or screening or treatment. And we forget that we are in Karachi, the Indus River flows through Pakistan, and we had a civilization, the Indus Valley civilization. More civilized than today, I would think. And it seems they had empowered women then. And they had these seals or what which are more impressive than our current ones today. And somewhere along the line, we've lost that civilization. We need to immunize for a healthy future. We need to invest in our girls and women, because girls and women are at the heart of development. When we do that, we improve health, we benefit families, we increase productivity of our nation, we reduce hunger, we create sustainable nations and strengthen economy. By just improving the health, by empowering. Thank you very much. So,
thank you very much, Dr. Sadia. It really was very enlightening. May I now request Professor Razia Korejo to kindly give her short comments on this talk, and then we can go ahead for the VIA video. Dr. Razia Korejo.
Thank you so much, Haleema. Thank you, Dr. Sadia. Very good talk on the presentation of this prevention of the CA service. Every year we are talking like this, and we have produced a website on this recommendation, on this guidelines of the SOGP to on this. So every time every year we are going to talk like this way, and we recommend it. But the implementation, that is the main problem of the implementation. We are talking so much, too much, but we can't implement. So on behalf of his SOGP, I will request all of the panelists and all of the journalists to please take the awareness and involve the government to use this type of the recommendation from the SOGP. Thank you so much.
Thank you, Dr. Razia. Dr. Sadia, I'll request you to kindly show us the video of visual inspection of acetic acid demonstration, please.
Okay, Haleema, I'm just trying to do that.
No worries, take your time.
मई में मुझे अचानक से टीबी शुरू हुई, जो कि हुई और बंद, फिर हुई और फिर बंद हो गई, जो कि मुझे लगा कि बहुत सीरियस बात है। और इससे पहले भी मेरा थोड़ा सा प्रॉब्लम चल रहा था, जिसके लिए मैं हर साल मैंने एक दफ़ा तो जाती थी, लेकिन एक से ज़्यादा भी मेरे विजिट्स मेरी गायनेकोलॉजिस्ट के पास थे। तो मेरे दिल में था कि कहीं कोई चीज़, क्योंकि कोई चीज़ थी जो इतनी लंबी बार बार हो रही हो, उसके लिए मेरे दिल में डर खुद से मौजूद था। तो बस पर मैंने उसके ऊपर मेरी उस वक्त मैंने एक्शन लिया, और मैंने डॉक्टर के पास गई और मेरी हिस्टेरेक्टमी हुई, और मेरी कीमोथेरेपी, जो भी कॉन्करेंट ट्रीटमेंट था, वो मुझे मिला, और अल्हम्दुलिल्लाह अभी मैं ठीक हूँ। बात सबसे इसलिए शेयर करना चाहती हूँ कि मैं पढ़ी लिखी हूँ, मैं अफोर्ड करती हूँ, मेरी रसाई ऐसे डॉक्टर्स तक है, अच्छे से अच्छे डॉक्टर्स तक अल्हम्दुलिल्लाह मेरी रसाई है। उसके बावजूद मैं 5 साल में समझें 3 बेहतरीन डॉक्टर्स के पास गई, और तीनों में से किसी ने मुझे मतलब पहचाना ही नहीं कि बीमारी क्या है। और मैं ये समझती हूँ, एक दफ़ा मुझे ये बीमारी हुई है, मेरी राय ये है, मुझे लगता है कि अब मेरे सामने कोई भी बात करता है तो मैं उसको फौरी तौर पर कहती हूँ कि नहीं, आप फौरी तौर पर पूरी इन्वेस्टिगेशन करवाएं। जो चीज़ 2009 में पकड़ी जा सकती थी पॉटरी करवा के, हो सकता है मेरी 2009 में नहीं तो 11th में 12th में मेरी हिस्टेरेक्टमी तब हो जाती, उस वक्त उसकी स्टेजिंग दूसरी होती। अब जब मैं पहुंची थी तो वो 2B उसकी स्टेजिंग थी, और वो जो था साइज का बहुत बड़ा था, लेकिन अल्लाह ताला की मुझ पर मेहरबानी थी कि वो लोकलाइज था। अगर वो फैल जाता وہ lymph nodes میں چلا جاتا اور جگہ organs بھی, کیونکہ یہ تو بہت ٹائم تھا. کہ میں جب یہ تکلیف ہوئی, ظاہر ہے کہ مجھے جب پتہ چلا کہ مجھے کینسر ہے تو مجھے لگا کہ بس اب میں یہ آف کورس میرے لیے دنیا مطلب دنیا میں ٹائم ختم ہو. مجھے یاد ہے جب میں ڈاکٹر کے پاس سے آ رہی تھی, جب ڈاکٹر نے کہا کہ یہ بہت پھیل چکا ہے, ہمیں نہیں پتا, تو سب مجھے لگا میں پورا راستہ یہ سوچتی ہوئی آ رہی تھی کہ میں دیکھ لوں, اب پتہ نہیں میں دوبارہ دیکھوں گی کہ نہیں دیکھوں گی. ایکچولی کینسر ایسی چیز ہے آپ سنتے ہیں اور آپ جو ہے نا بس آپ کو لگتا ہے کہ بس یہ تو مجھے نہیں پتا کہ مطلب مجھے میں ابھی بھی اس زندگی کو مجھے ایسا لگتا ہے کہ یہ زندگی اللہ تعالیٰ کی مجھے مطلب اٹس اے بونس لائف, اور میں پوری کوشش کرتی ہوں کہ میں اس بونس کو جو ہے بالکل اسی طرح گزاروں کہ جس طرح بیسٹ طریقے سے گزاروں, کہ کوئی چیز اگر جو رہ گئی تھی مجھے سیریسلی ایسا ہی لگتا ہے کہ یہ بونس ہے. ویکسینیشن کا مجھے اس سے پہلے کسی نے نہیں بتایا تھا. ویکسینیشن تو انفیکٹ جب وہ اناؤنس ہوئی تھی جو آ رہا تھا ان دنوں, بلکہ میں اس وقت اسکول میں پڑھاتی تھی, تو جو میری خود بھی بیٹی ینگ ہے اور بھی جو مدرس تھیں وہ یہ ڈسکس کرتی تھی کہ پتہ نہیں کس کے لیے, سب کا یہی کانسیپٹ سب کے مائنڈ میں یہی ہے کہ یہ ہمارے بچوں کے لیے نہیں ہے, یہ ہمارے بچوں کے لیے نہیں ہے, تو لہٰذا یہ ان بچوں کے لیے ہے جو کہ سیکشولی ایکٹیو ہیں, تو ہمارے بچوں کو تو انجری کی ضرورت نہیں ہے. تو بس ہم بڑوں میں سے تو کبھی بھی کسی نے نہیں سوچا کہ آپ کروائیں گے. جیسے میموگرام کا سب میں پتہ ہے کہ کروانا ہے, سب کوشش کرتے ہیں کہ ہم کروا لیں, لیکن اس ویکسین کا کسی کو بھی نہیں پتا کہ ہم نے لگوانی ہے. ویسے سے پہلے میں یہ بولوں گی کہ میں نے سب سے پہلے اپنی ایک بیٹی کی کروا لی ہے, اور جو بڑی بیٹی ہے اس کی جو یہاں تھی نہیں, اب میں اس کو وہ بھی کرواؤں گی. اور میں ایک اور چیز آپ سے شیئر, یہ سرویکس کی جو سرویکسل جو ویکسین جو ہے سروائکل کینسر کی جو ویکسین ہے میں نے اپنی بیٹی کو کروائی ہے جو کہ 18 ایئرس کی ہے. اور اب میں نے بلکہ میرا بیٹا جو 20 ایئرس کا ہے, مجھے پتہ چلا کہ لڑکوں کو بھی ہوتی ہے, میں نے اس کو بھی یہ ویکسین جو ہے وہ لگوا دی ہے, اور اب میں اپنی بڑی بیٹی کو لگواؤں. اپنے فرینڈس میں بھی جب بھی میں جاتی ہوں, اگر کوئی ایسی بات آتی ہے یا مجھے یاد ہوتی ہے تو میں ضرور ان سے یہ شیئر کرتی ہوں, اور سب کو انسسٹ کرتی ہوں کہ اس کو مذاق نہ سمجھیں, اس کو سیریس سمجھیں اور اپنے بچوں کو ویکسینیٹ کروائیں. اور آئی وش کہ ہم اپنی جس طرح پولیو کے ڈراپس بھی دیے جاتے ہیں, ہماری بھی گورنمنٹ یا ہم بھی کچھ ایسا کر سکیں کہ ہم اپنے لوگوں کو, اپنے بچوں کو فری ویکسین لگوا سکیں, تاکہ ہم اپنے بچوں کو سروائکل کینسر سے بچا سکیں.
Thank you, Dr. Sadia. It was really sobering and it was really eye-opening for all of us. I wish the message gets really spread to the places where we really want it to go and reach. Thank you very much for having, I must appreciate this lady as well. So can we now have the demonstration video, Dr. Sadia?
Yes, Aliya, I will just try to share it. Can you see this, Haleema?
Dr. Sadia, you'll start sharing, and yes, we've started seeing it. Thank you. It has started.
So 20 minutes of boiling the instruments, and this is what you need to do a VIA, your instruments. Here's a client waiting for her checkup. You see the nice smiling attitude of the nurse calling her in, making her relax. She washes her hands properly, as we are teaching these days for COVID as well. With soap and water. She's putting on the gloves. And these don't have to be sterile gloves, but your instruments have to be high-level disinfected or sterile. So the Cusco speculum is inserted to visualize the cervix. And this is 0.5% acetic acid. And all you need is a torch or a lamp to inspect. The swab is applied with the acetic acid and thrown away in your infected waste container. And there is no acito-white lesions, and you have a result there and then. And of course, she's going to use the infection prevention measures, disinfect her gloves and the instruments to be reused. She calls in the next client. Again, washes her hands. You must do that in between patients with soap and water. Gloves on. Visualize the cervix. And here, after application of acetic acid, in this cervix, you are seeing these lesions, these white spots. So this lady will have to be referred. So thank you. That was just because a lot of people don't know how simple VIA is, and it can be done at any clinic, any outpatient clinic, and we can teach our residents and our junior doctors. It can be done at the time of insertion of an IUCD or endometrial biopsy, any procedure where we're doing a speculum examination. This can be easily done and taught. So I will request Dr. Haleema to introduce our eminent panelists for our panel discussion now.
Yes, Dr. Sadia, I'll request all the panelists to kindly switch on their videos for some short while we are introducing them, and then we can all switch off when the question answer session starts. I'm really pleased and grateful to all worthy and eminent panelists for being here today. It's not only professionals from different professional bodies, but members of civil society, journalists, poets, writers, and community leaders who are ready to be with us today to hold hands, create awareness on this very important issue of women health. So thank you very much to all of you for being a part and being elements of change for this cause. May I introduce Professor Dr. Shahida Zaidi. Dr. Shahida Zaidi is a very renowned name in ultrasound, but she's been a practicing gynecologist all through her life. She's been past president of AMAN. Dr. Azra Ahsan, current president of AMAN and past president NCMNH. Professor Dr. Rehana Rahim from Lady Reading Hospital, Peshawar, a member of Gynecological Cancer Registry Board of SOGP. Professor Dr. Nusrat Shah, also a member of Cancer Registry Group of SOGP. Dr. Aliya Begum, a consultant at Aga Khan University Hospital and chair of SAFOC Committee of Gynecological Cancers and co-chair of Gynecological Cancer Registry for SOGP. Professor Dr. Nabila Shami, a member of SOGP Oncology Committee from Lahore. Professor Roshan Qazi from Hyderabad. She happens to be the chair of the Hyderabad chapter, as well as a very senior and very active member of society to work in this regard. Dr. Rehan bin Asim, who is a gynecological oncological surgeon at Shaukat Khanam Hospital. Dr. Ruzila Khan from Aga Khan University Hospital, who's been a part of Teal Ribbon Alliance of SOGP right when we started it. We also have radiation and clinical oncologist from Atomic Energy Medical Center, Dr. Hina Hashmi, Dr. Nasir from Aga Khan University Hospital, and Dr. Azra, the clinical oncologist from Kiran Hospital, Karachi. We have colleagues from Pediatric Association and Family Physicians, including Dr. Khalid Shafi, Secretary General of Pakistan Pediatric Association, Dr. Ali Mirza Azhar Sahab, who is the President of Pakistan Medical Association, PMA, who will definitely work with us in this matter. Madam Dr. Shehla Naseem, Secretary General of College of Family Medicine. We are fortunate to have people from NGOs and healthcare organizations like Dr. Fawzia Asad, who is the country manager for JPIGO, Dr. Qudsia Uzma, country manager WHO Islamabad office, Dr. Sufia Yunus from Extended Program of Immunization Pakistan, Madam Mehtab Akbar Rashdi Saiba, who is president of Family Planning Association of Pakistan, a renowned TV star of her time and a very loved person by all of us. She has been a very good, great advocate for women's health on all such matters. Madam Nurul Huda Shah, who's a writer, poet, and an active member of our civil society. I'm really grateful for her to join us today with us today. Madam Mrs. Sheher Bano, she's a journalist who works on healthcare related issues. Most of the journalists don't like this topic, but I'm really grateful if she's opting to work on this domain. This is a great work you are doing for the women of this country. We will be having members from Ministry of Health, Government of Sindh. Health Minister Madam Azra Pecho, inshallah, will join us and she will talk about the way forward. And Dr. Talib Lashari from CIP Secretariat will also represent Ministry of Health, Government of Sindh. Thank you very much for being with us today. Dr. Sadia, now I give over to you for the question answer sessions and panel discussion.
Thank you, Dr. Haleema. My first question is to Dr. Shahida Zaidi, because we are very fortunate to have somebody like her with us today. She has, with her experience with FIGO and WHO and, the SOGP, and President AMAN. So today she's representing AMAN, which is Association for Mothers and Newborns, and which is the NGO arm of National Committee for Maternal Health. So Dr. Shahida, I would like to ask you what, we saw this video earlier that AMAN made. Could you just share with us what AMAN has been doing in the past few years and what it intends to do in the future regarding cervical cancer prevention?
Okay. Now, AMAN has been collaborating with SOGP as well as the National Committee for Maternal Neonatal Health in carrying out advocacy. It has been holding cervical cancer awareness events, explaining the value of screening to the health providers as well as the public in some cases, and also the value of HPV vaccination to young girls. And the video that you just saw was also carried out by or made with SOGP and National Committee. And it has also been carrying out seminars and workshops in screening and early diagnosis of cervical cancer by pap smears, by VIA and colposcopy. And it has been doing this for at least 7 years that I know of, especially in January when the which is the month of cervical cancer, and also at the request of institutions which asked for any of these workshops to be conducted. And now AMAN, in addition to the two organizations that I mentioned, is now joining hands with the Pediatric Association in order to push for HPV vaccination to be included in the EPI schedule.
Thank you, Dr. Shahida. Thank you very much. My next question is to Dr. Azra Ahsan, who is Vice President of National Committee for Maternal Health. And we know that you are jointly working with SOGP and AMAN. You are also doing a lot of work in postpartum contraception, PPIUCD, and postpartum family planning. As a gynecologist and clinician, what do you think about teaching the technique of VIA to all our doctors during our trainings, and also trickle down it down to nurses and midwives? What do you think about that?
Thank you, Sadia, for giving me this opportunity to be a part of this awareness campaign. And as Vice President of National Committee for Maternal and Neonatal Health, I have a full support of our President, Dr. Sadka Jafri, who is so well respected. And what is very important to know is that we need to do this intervention at all levels of, for not only creating awareness, but implementing the vaccination, implementing the screening program too. So as you showed the video, performing a VAI is not difficult at all. So it is a technique which can be easily taught not only to doctors but to all cadres of nurses and midwives also. And I think it is easily taught. And because AMAN and NCMNH and SOGP in collaboration do so many trainings, we volunteered to take this forward. And whatever trainings that we do from now on, we can include this visual inspection with acetic acid as a part of that training program for with the monk or postpartum family planning and all, because it will take very little time and it is easily taught. So, but it is, and talking about vaccination also, I'm a clinician, I see patients, and unfortunately at those times when this vaccination was also available in Pakistan, and in spite of talking so much, very few patients actually took this opportunity to take this vaccination, even those who could afford it. So we need to, create this awareness in the civil society. Hopefully, whenever it will become available again, that it is included in the EPI schedule, and also, so that women are aware that it is important to take this for their girls and sisters and daughters. Thank you.
Thank you, Dr. Azra. I will next address my next question both to Professor Nusrat Shah and Professor Rehana Rahim. Both are working in large tertiary care government hospitals. Nusrat is in Civil Hospital Karachi, and Professor Rehana is at Lady Reading Hospital, Peshawar. And I just want you to share with us what kind of cervical cancer patients you see, and in what stages do you usually see them in your hospital? Dr. Rehana first, Professor Rehana Rahim.
Thank you, Sadia. Thanks for inviting us.
Just a minute, Rehana, can I request somebody's mics are on and a lot of disturbance is coming? I will request the others to mute their mics, please. Thank you. Yes, Rehana?
Thank you, Sadia, for inviting me to such a prestigious occasion and such an important cause.
I think you are communicating through two devices. Keep one slightly away.
Okay, now is it clear, Haleema?
Yes, better.
Okay.
Much better.
Being a tertiary care hospital, we are seeing a lot of patients now. Perhaps in the last year 2019, pre-corona, there were about 26 cases of cervical cancer, and as expected, they all presented at a very late stage. stage 3 and stage 4. And apart from doing biopsies and confirming the diagnosis, we couldn't do much. As we know, the cervical cancer research centers or any cancer research centers, particularly in KPK, are very scarce. We have recently started referring our patients to Shaukat Khanum Hospital, but as we know, the chances of getting better, getting a cure at this stage are very, very low. Now, talking of prevention in terms of offering vaccination would be the best idea, but again, we know that would only eliminate cancer by 0.1% in next 10 to 20 years. So perhaps screening is the best option. And if we cannot offer a strategic plan for that, probably an opportunistic screening. Whenever you see a patient in outpatient clinic, tell them to have a smear there and then and await the results. Would be better idea to start with. And again, SOGP would be the first forum and perhaps the best forum in collaboration with WHO to start with pilot projects in all the teaching hospitals to assess the burden of the disease and then to take it from there. And I'm hoping full cooperation of SOGP and WHO because we have to offer some sort of incentives to the doctors saying that, look, this is a pilot project, you will be rewarded, you will be given a CME certificate, your study will be published, and this is how we are going to take this and motivate our younger generation in terms of making cervical smear as a routine practice.
Okay.
And of course, trying to refer the patients at an appropriate time to good centers in Pakistan.
Okay, thank you, Rehana. Now, Professor Nusrat, can you share with us your experience with cervical cancer at Civil Hospital? Okay, I don't know if she can hear me. So in the meantime, I'll
Hello.
Yeah, Nusrat,
Hello.
Yes.
Can you hear me?
Yes, we can hear you now.
Yes. Okay. Okay. Thank you, Sadia, for this wonderful joining different stakeholders for this very important program and doing this comprehensive presentation also on CS cervix, basically screening and prevention. So you asked what type of patients we see. So like Rehana said, we usually see patients at the late stage because we don't have a program of screening the general population. So even if we are doing screening, that is for symptomatic patients who are coming with postcoital bleeding, patients who are coming with irregular abnormal bleeding. Only then we are doing pap smears. We're not doing pap smears for normal patients who are asymptomatic but sexually active. So that means pap smear is not the way forward for Pakistan because we do not have a program for general population. And when we get patients, we get stage 3 and stage 4 because usually they come at the stage of renal failure. When we do these biopsies and there are large tumors already, more than 4 centimeter, 5 centimeter, fungating tumors already spread to the rectum, already spread to the bladder. So most of the time we just do biopsies and then refer them for radiotherapy to Kiran Hospital, to Dr. Asghar and all these colleagues who then do chemoradiation and then further follow-up. So mortality is very high, just like you said. This is the most common cancer. And the important thing that you said is that this is the only cancer which is preventable actually. So we get ovarian cancer at a very late stage, but then we can't do anything about it because there's no screening, practical screening program for ovarian cancer. But because CS cervix is preventable, the most important thing is that we do this EPI, we include this vaccine in the EPI program, and we have to sensitize the government, we have to sensitize all the partners that we must do this. Hello,
Yes.
can you all hear me?
Yeah, we can hear you.
So yes, at tertiary care center, it will be very important to teach. We are teaching the students, we are teaching our residents about these techniques of pap smear, but we are not doing anything practical for prevention. That will only be done if we have this vaccination program, like you said. If it's a very cost-effective intervention, if we can give just one dose, non-valent, to all girls in school, that will be the best thing to go forward. And I think we need to have a data generation from all over the country, and all gynecologists should be sensitized and join hands that we must have this done on SOGP platform, with the, of course, collaboration of all partners, that we create this registry and we collect all this data from all the tertiary care hospitals where we are getting this CA cervix in late stages, so that will be important for advocacy, that we we are not saving these women. Totally avoidable cancer, sexually transmitted cancer, and totally avoidable by means of at least the vaccine, if not the pap smear, because pap smear practically we are not using all over the country as a screening program. We are doing it at a later stage. Whenever the patient is coming with symptoms, only then we do the pap smear. So that's not the way forward. I mean, we are not preventing anything with that. The only thing I think that can prevent is the vaccine. And we must start advocacy and data sharing with the government, so that we must make this possible.
Thank you,
Thank
Dr.
you.
Nusrat. I will next address Dr. Rozila Khan, who is working in a private setup at Ahsan University Hospital. And I would like her to share that, you know, her experience in a private hospital and how much, how costly it is. You know, people forget that even at government hospitals, although the patient most of the time is not paying for the treatment that is being offered, it's actually as expensive or perhaps even more expensive treatment than in a private hospital. The only difference is it's not coming from their pocket, it's rather being paid by the taxpayer in the government hospital. So Dr. Rozila, can you share with us the challenges you face when these advanced cervical cancers present to you?
Thank you, Dr. Sadia. Thank you, SOGP, for this opportunity to really address and be a part of this important event. It's a very traumatic situation for the patient, obviously, when they are diagnosed with cervical cancer. And in many instances, it's the histopathology post-hysterectomy, sometimes even, when a young patient who has gone to a simple gynecologist and has had a hysterectomy done, and there is no pap smear that has been done prior to it, and they end up having residual disease. So sometimes we get patients at a stage where they've had partial treatment. We have patients who sometimes come in with disease and irregular bleeding, which has been treated with hormones for a good part of a number of months and sometimes even years. And then we have a group of patients who comes in with sometimes even with an HPV report. I would hazard to say that our society hasn't started to think about, and the consumers have started challenging this status quo by sometimes even going and getting their tests done. So I would just venture here to say that we see diseases at really remarkably advanced stages, like in the government hospital, because the patient has gone from pillar to post, going from here and there, trying to know what's happened to them. If we have an opportunity to prevent this disease, which we have been, and most gynecologists have been trying for for so many years, if we address this situation, it would be an excellent opportunity to prevent this disease. But the cost of the management is immense. Your video that you showed of this patient and the distress that you could see in the eyes of this patient was really remarkable. And if you can see that she's gone through a very traumatic event, and then at the end of it now doesn't want anybody to suffer and is willing to come forward. In private hospitals, when you go and get such treatment, there are 3 phases of this treatment. It's the surgical treatment that we do, and obviously it means inpatient care, a long stay in hospital, a number of lack of rupees for the treatment just for the surgery. And then that's followed up with possibly even with radiation therapy and chemotherapy for those who have advanced disease, such as stage 2B and onwards. And they end up having displaced from their homes. Obviously, if they are coming to Karachi for their treatment, they're staying in hotels, they're staying in places, and they're displaced from their homes, which makes them just want to abandon the treatment. So it's an emotional traumatic, and like your slide showed, that we have almost 8,000 women who are dying from this disease every year in Pakistan. And that's just the tip of the iceberg. So I would say, Dr. Sadia, that the treatment and the burden of treatment in a private hospital is huge. And the cost is always borne by the patient and her family. And obviously her family, in case her disease is more advanced, means a number of, it's not a one-time treatment. It needs various episodes of treatment, coming to the hospital again and getting treatment all over again when this situation occurs. And we're talking about advanced disease, we're also talking about more and more radical surgery. So when we're talking about radical hysterectomy, and sometimes even in situations about a complete exenteration or an anterior exenteration, which is even more complicated surgery. So I would just want to end my opinion in this situation, that this is a very, very important area, and if we do not address this, we'll be really left behind, because most of our Western counterparts in terms of medical management are far ahead of us.
Thank you, Dr. Razila. I coming from the private setup also, further validate what you're saying, because it's very, very expensive, not just the treatment, but the investigations from CT scan to you name it, it adds a lot to the burden of the disease. I will now request Dr. Rehan, who is from Shaukat Khanam Hospital, Lahore, and he is perfectly poised to give us a comparison. He has recently come back to Pakistan from the US, having practiced there, and I would like him to share his experience so far of dealing with cervical cancer in Pakistan as opposed to the US. Dr. Rehan.
Thank you very much. Thank you very much. Pardon my my sound. I'm having an upper respiratory infection, so please pardon that. Thank you very much for inviting me to listen to this very informative and concerning topic in Pakistan. Well, you gave us a great intro on cervical cancer, HPV vaccination, the pros and cons, and the hurdles we've been facing as a society. I mean, there's no comparison between a developed country like US or industrialized country like US, or for that matter's sake, Europe, to Pakistan at all. Pakistan is not even in that list at all. So, looking at US, you can imagine that having a preventive exam is part and parcel of every individual, whether male or female. You take your kids every year for a health checkup. How often do we take our kids, healthy kids, without any ailment, to a primary physician or a pediatrician for that matter's sake? Never, never. Same thing with females, males for that matter's sake. How often do we go to a physician and ask them, okay, do my preventive exam, I want to have my breast exam, I want to have my pelvic exam. We don't have that setup here. So obviously one of my esteemed colleague made a comment that, well, a better deal is always a prevention than early detection in a developing country scenario. And that's true to the core. That's right on the dot, spot on, that if we want to change anything in Pakistan scenario, that would probably be vaccination, vaccination, vaccination. So I never worked in Pakistan before coming and joining Shaukat Khanum. I was trained, did all my work. I lived in US for 20 years. I'm a new kid in the block, on the block. And you can imagine that, this is the first time I have, when you called me the other day, I came to know that we have a society of OBGYNs in Pakistan as well. I'm a member of ACOG, proud member. Not only that, I have a business degree in my field as well. So
well, time to become a proud member of SOGP then.
Absolutely, absolutely, absolutely. So when I came to Pakistan, there was a question from Shaukat Khanum that we wanna start awareness for HPV vaccination, but you can imagine that the disease burden of cancer is so much that we hardly have time to invest into primary prevention as a gynae oncologist. We have too much load of our patients who come to our door at an advanced disease. It's not that they're diagnosed at advanced disease, it's that they're mismanaged at an advanced disease. It's not someone I can blame from outside my fraternity. It is my fraternity that's responsible for this. It is my outside OB-GYNs who are responsible. If you don't know how to treat it, don't treat it. Consult somebody, refer that patient, ask a second opinion. It's okay to ask. I don't know everything. If I don't know everything, when I come to know something different or something out of my experience, I ask. I go to an individual who knows. I'm like, okay, give me a suggestion. What should I do? I don't feel shame in asking. So the first and foremost responsibility as an individual of this fraternity is raise awareness among my colleagues first. Because the first thing, it's not the consumer that gets the information to the provider. It's always the provider that shares the information. Consumer did not go to Apple that, okay, I want an iPhone. No, it's the Apple that made an iPhone, came to the consumer and said, look at this. I made a wonderful device for you, use it. Everybody loved it. Same thing with this. It's a very, very basic principle. If we want to do this, we want to have our colleagues telling the patients that, okay, you need to do this. And obviously, we're going to start with opportunistic screening as well. That's another thing we need to do. But the most important thing is making a hard stop for immunization, meaning our girls, our daughters, our sisters, they go to schools, colleges, make it a hard stop, okay? 5th grade, you can't go to the 6th grade until you show me the card, immunization card that you've been vaccinated, not only for HPV, but all the essential EPI mandatory vaccination list, like polio and whatnot. You know that developed country has eradicated polio. It's us that are still struggling with same thing, polio. So if we want to instill into our next generation, into our current fraternity, we need to raise voice. We need to teach our individual colleagues that, okay, patient comes in, tell her that today I'm going to teach you, this is the handout, go home, read on it. I want you to get safety from the cancer, and this is how you're going to do it. That's one thing. Make it EPI mandatory schooling program or college program, either one. Obviously, it's more cost effective if you do a schooling program because you only need 2 doses. 5th grade, make it a hard stop. Nobody can go to 6th grade until you provide a vaccination card. It's only 2 vaccines. Make schools accountable. Make schools invest into, schools charge 50 grand, 60 grand, 70 grand tuition. I mean, I am amazed to see so much tuition in Pakistan, and still we are illiterate. I mean, it's out of my understanding. How are we surviving?
It seems like you're getting a real cultural shock, and welcome to Pakistan. And we need more people like you to change things, Dr. Rehan. So, yeah, is there any other point you wanted to make? You're just it seems you're inundated with advanced cancer.
Well, I
which
totally
you,
understand. The first thing,
yes,
I'm
carry
sorry.
on.
The first thing is we need to, people like you who have a clout, who are stronger in the society. They have connections. You guys can change things. You can bend rules.
You have to be part of that society, and you have to be part
To
of the
accommodate.
change.
So in order to do that, if we can make the government provide us with cheaper vaccine, bring those companies on board to provide us with affordable vaccine. And then the next phase is obviously teaching the public. Obviously, the onus is on us as individuals, like gynecologists, primary care physicians, pediatricians, all have to step forward and make this awareness. Because obviously, when I see a patient, they're already advanced disease. They're not surgical candidates. They are
Yes.
not. In the last 1 year, I have not done a primary radical. I'm not talking about salvage surgery. Primary
Yeah.
radical procedure for cervical cancer, not even one. I've been doing colposcopies here and there, but obviously we need to teach our next generation colposcopy. We need to teach our next generation how to do pap smear. And obviously opportunistic pap smear is the way to go in our setup. But I'm glad that you're raising awareness. You have brought everybody who is important in the society together. Hats off to you. Thank you.
Well, we are hoping that you will join hands with us with our trainings, and inshallah. So we will be in touch with you, Dr. Rehan. Thank you very much. And we have
Thank you.
another gynecologist here, Professor Roshan, who is from Interior Sindh, Hyderabad, and has a vast experience. So I will ask her briefly to give her few comments. Dr. Roshan,
Thank you,
if
Dr.
you're
Sadia.
there. Ji,
Yes.
Assalam.
Can you hear me?
Yes.
Sadia, can you hear me?
Yes, we can hear you and see you.
Right. Thank you very much for inviting me for this very informative seminar. The question is that whatever has been discussed, I fully agree with that. I haven't observed any change in the cervical cancer incidence or even the screening programs in the last 3 decades, I can say. My dissertation topic was incidence of CS cervix in Hyderabad region, and I have collected the data that time from Atomic Energy Center of Hyderabad, Jamshoro. The question is that time CS cervix patients were coming in the latest stage, and even today we see the patients in very late stage, stage 2B, advanced, and stage 3 and stage 4. So nothing except radiotherapy can be done much. Now, I have started a program of screening by pap smear in Gynae Unit 4 from 2002 to 2004, and we have practiced doing pap smears and sometimes Schiller's test that time. VIA was not introduced that time. So, out of 600 patients, we have seen only 4 positive smears. And in those 4 positive smears, when we did hysterectomy for one patient who was multiparous, the histopathology report didn't show any dyskaryosis. The question is that for that, I thought and still we were receiving the patients with advanced disease. That has, in my mind, limited the sensitivity and specificity of pap smear, and that is always a multifactorial thing, means a pathologist evaluation, the cytopathologist. So it is something which has to be taken in account, that where the smear is gone, how the smear is taken, and I think doing VIA is simple, cost effective, and if we are teaching even the LSWs and the junior level and the interior Sindh, we are speaking mostly about Karachi and the centers, Islamabad, Lahore, and the big cities. No, the thing is very different. So pap smear is something which might not be very effective for screening in our country. VIA is the better option, and we should put forward the training, and we should make more convenient the training for everyone, the nursing staff, the LHWs and others at the ground level, and even our senior colleagues and the junior colleagues should be trained for this. Number 2, vaccination, if we are saying that government will put this vaccination in the EPI, Dr. Azra will be joining soon, and I hope she will consider this thing, but this seems to be very impracticable, that government will give EPI and with EPI, HPV vaccination will be included. It is expensive, so till WHO and government of Pakistan on board, the federal government is thinking on that. It is a good initiative by SOGP, AMAN and others and the Teal Ribbon organization that they are thinking in terms of including it for the girls in EPI program. But this seems to be impracticable. I hope these all things which you are putting forward will be considerable, will remain under consideration of our higher authorities and the government and then the policymakers. And I hope in future we will be able to reduce the cancer and cervical cancer in our
Thank you, Professor Roshan. And that's why we have invited Dr. Talib and Madam Azra Pecho. So hopefully she'll be joining us. My next query is towards the our radiation oncologists. We have 3 eminent oncologists, radiation oncologists from Karachi here, and Dr. Nasir from Ahsan, Dr. Asghar from Kiran, and Dr. Hina from the JPMC Atomic Energy.
Thank you, Dr. Sadia. Can you hear me? I'm Dr. Hina from Atomic Energy Medical Center.
Yes, can you just share with us the what you see and the the burden of radiation treatment?
Yes, thank you, Dr. Sadia. It's a pleasure for me to be here among the panelists. And in Atomic Energy Medical Center, we had a lot of cervical cancer patients which are being referred to us from interior Sindh. And as in everybody's experience, nearly more than 80% of these patients are in the local advanced stages. And apart from this, the poor nutritional status of the patient, the low socioeconomic income, the financial constraints, low hemoglobin levels, they are all the challenges which we have to face while treating these patients. As we all know that in the locally advanced stages, the concurrent chemoradiation with followed by brachytherapy is a standard of care. And the treatment, as we all know, is so lengthy, it is painful, and with all its side effects, the delayed side effects, which is interfering with the quality of life of the patient. So it is utmost important at this point that we should emphasize on the prevention and early detection of the disease. And it's a good forum to raise awareness among the masses. We should educate the general population to identify the means and routes to which are the cause of the spread of this disease, because it is a preventable disease. And apart from this, I would also emphasize on the need for the formulation of a national cancer registry program, because this is lacking in our scenario, and this cancer registry program will be the actual reflection of the disease. We need to know the actual burden of disease, and for that we have to emphasize for the need of this national cancer registry program. In Atomic Energy Medical Center, we are treating the patients in local advanced stages, and in external beam radiation is followed by brachytherapy also, which is also again a very lengthy procedure, a costly procedure. So this should be, instead of going through these treatment, we should all emphasize and make it implemented that the need for the prevention and early detection is of utmost importance.
Okay, thank you. So Dr. Nasir, you represent the private sector. So can you share with us the cost of this this very expensive treatment?
Assalamu alaikum warahmatullah. Thank you, Dr. Sadia, for inviting me as a panelist. I have watched whole of this program. This was actually really informative for me as well. I want to share few things which I have experienced in my practical life. First of all, I should say that there is a lack of coordination between among the oncologists. We have been discussing with our Atomic Energy Medical Center colleagues, Dr. Hina Hashmi, Dr. Asghar, that if patient is receiving external beam radiation at somewhere center in the interior Sindh, they should coordinate with the atomic energy medical centers in Karachi in advance so that there should be no delay in completion of treatment. One thing I should clearly mention that for squamous cell carcinoma, anywhere and especially for the cervical cancer, if we have to complete the treatment within 7 weeks as a total duration, external beam along with brachytherapy, this treatment should be completed within 7 weeks. If there is prolongation of treatment time, means there are delays in terms of referral rates, in terms of complications, whatever the strikes, etc., what machine breakdowns, whatever it is. 1 day treatment gap reduces local control by 1.5%. Means if we are treating a patient, completing a patient's treatment within 7 weeks, and we are expecting cure rate or local control of 65%. If we treat this patient in 8 weeks, we will lose 10% of local control, because whenever there are gaps, there is a repopulation of the tumor. One thing is this. Another thing is that patients are not properly consulted, are not properly examined. Few days ago, I got a patient who was treated at a known kidney hospital in Karachi. She presented with raised creatinine. Her cystoscopy was done. Then bilateral DJ stenting was placed. Few days later, her creatinine came down, and then she again went there, and the DJ stents were removed. Few days after 2 weeks after this removal of the DJ stents, she again presented with raised creatinine, and at that time it was examined that she has locally advanced CA cervix. So you can assume and you can see how careless our physicians are, that they are doing cystoscopy, but they are not examining the cervix. How far is the cervix from the urethral orifice? So this is the real scenario. This is, हम कहते हैं कि ये दुख है हमारी कौम का. तो अब ये है कि जो cost है treatment की at private center, it's usually external beam radiation cost for 300,000 to 400,000 rupees, mean 3 lakh to 4 lakh rupees, and brachytherapy another 150,000 rupees. So chemotherapy is very cheap if patient presents in early stage disease. The chemotherapy which usually is given is cisplatin, and the 50 milligram vial of cisplatin costs about 1,000 to 1,500 rupees only, and it has to be given weekly.
Okay, thank you, Dr. Nasir, for giving us a reality check, because as I said, people forget that this treatment is not free in Kiran or in JPMC either. That is the real cost, and perhaps more, which taxpayers pay through the government hospitals. And when you compare that to the cost of the vaccine, which is less than 5,000 rupees, it just put us all to shame. Dr. Asghar, I see you. Would you like to put in a comment as well about radiation therapy? Okay, I think we've lost Dr. Asghar. So I will address the pediatricians now, and pediatricians and the PMA through Dr. Our Secretary General, Dr. Mirza Ali, and I will also address this question to the Family Physician Secretary General, Dr. Shahida. Would you like to comment on what role your organizations can play for the prevention of cervical cancer? Dr. Khalid. Would you like to go first?
Thank you very much.
Pediatric Association?
Maybe, as you say.
Yes, okay. Please go ahead.
Bismillah. Thank you very much. Pediatric Association is always ready to play the role in every health problem. And the immunization is obviously a main source of decreasing the burden of disease in a resource-limited country like Pakistan. But talking about the immunization may be easy, but when it comes to practical, it's very difficult. We are not able to convince our parents to give polio drops. Dr. Rehana mentioned so many things, but I will add to him that in the Pakistan, we have to first educate our doctors. Still, there is anti-vaccine lobby. So talking about the prevention of cervical cancer, every vaccine which is available against any infectious disease is most welcome, like the cervical cancer vaccine. We have some failures in our part when this vaccine was commercially available. We were not able to convince even a small fraction of the population. And if we have started using this vaccine to even the affording population, then we would be in a better position at the moment. So first of all, this vaccine, we should again try to make it available to those who can afford. And at the same time, we should continue our struggle to add into our existing PPI program. And the Pediatric Association will fully cooperate because this vaccine will be conveyed to the parents in a way that when they complete the primary course of the immunization, the boosters at the age of the 5 years will tell the parents that there is another vaccine. People are asking. Many people do ask us, is there any vaccine left at 5 years of age when we finish the vaccination with the DPD booster? We will be telling them there is another vaccine for the girls. But we have failed previously to convince our even pediatricians and other doctors to tell the parents about this. But we should start working again with this, and Pediatric Association fully support this vaccines, your strategy to for the cervical cancer vaccine.
Thank you. Dr. Sheila?
I again endorse what Dr. Khalid Shafi has said, and I must make it known that about 70% of the patients, the first visit is to a family physician or a GP. So I think we have a very strong first step to conquer there, and we need to enhance awareness amongst our members. And so that if anybody presents over there, they should know how to manage it or how to refer it appropriately. But I personally believe that there's a huge amount of work has to be done in terms of awareness amongst the people and also amongst the doctors as well. We have around, in Karachi, we have we train around more than 1,000 doctors every year, and who are actively doing CMEs with us to enhance their knowledge. So if you would like to, send us these materials, we can make it a part of their, the 11-month CME course that our doctors attend. Or we can also offer them, free of cost, so that they can, get the certification and get the awareness. I think this is very important. So once they know when to do, what to do, things will automatically improve. But it's not a single-pronged approach. It has to be done from every side. So we train the doctors, someone increases the awareness, the pediatrician does his part, and when the patients eventually God forbid, if they end up with a gynecologist, they should then how things work out, that part is also there.
Yes.
So I think it's not a single prong, but it's a multi-pronged approach that has to be taken. Thank you so much.
Yes, Dr. Sheila, that's why we invited you. And of course, we can do this for you. And then similarly, you can conduct your trickle-down trainings. I will come to you, Dr. Asghar, after I've taken a comment from Dr. Azhar. Dr. Mirza Azhar, would you like to make a comment what PMA can do about this, about the prevention strategy? I don't know if he's there. Is Dr. Azhar there? Mirza?
I saw him in the start of the meeting, Dr. Sadia.
Yes,
now
he was there. We seem to have lost him. So, Dr. Asghar, would you like to give your comments from Kiran, your experience with the radiation oncology for cervical cancer? All right. Your mic is mute, Dr. Asghar. Yes, we can see you now. Yes. But we can't hear you. We can see you, but we can't hear you, Dr. Asghar. Yes, now we can hear something.
Okay, sorry. This might be some issue. So actually, we people are treating cancer in the Kiran hospital, and what we are facing the scenario over here is almost the same which you have shared with us. But fortunately, things are now on the better side. We have two linear accelerators freshly installed and quite latest technique, and we can start the treatment within the due time, and the chemo can be done within the due time. And it's not so expensive, but most of the time people are getting free of cost over here also. Situation is that the people who are coming to us with a locally advanced disease, how much is the cure rate? It's quite almost, you can say it's very negligible. We can't cure properly, but we can have a very good control rate with the cervical cancer. We have seen few patients which have been very well operated well in time, and they are quite well managed up till now, and they are doing very well. But it all depends if you can detect them early, and then you can manage accordingly as per the guideline, then very well it can be managed. Unfortunately, the people who are coming from the interior side and being managed by some local gynecologists, not the senior professor level people, they are mismanaging the thing. No, and similarly over here in most of the center here in Karachi, they are mismanaging such cases of the CS cervix. So we need to have a good campaign, and we should have this more seminar with these gynecologists who are treating cervical cancer, just like by doing simple THBSO. And this is the reason behind that this is not being well managed. But I can assure you, if this patient is coming to us here in Kiran, we can manage them even without any single penny. If they can't, our treatment cost is in Kiran hospital not more than 50,000-60,000 rupees total treatment cost, including brachy and radiation therapy. So I assure you, if any patient coming to us, we'll manage accordingly. Thank you very much.
Thank you, Dr. Asghar. You are doing amazing work. And what we have gathered from all of you who are dealing with these cancers is virtually all of them are presenting in late stage where they cannot be cured. And I will now move on to our next set of panelists, and I will request Mrs. Mehtab Rashdi, who is, a member of our civil society as well as being involved with Family Planning Association of Pakistan, and I know that they themselves did some research and training with cervical cancer prevention. Yes, Mehtab, please.
Alaikum Sadia, very nice of you to have me here on this panel. I've been listening to all the panelists as well as had the opportunity to go through your presentation, which was very, very informative and eye-opener for people like me, but I think most of the people who are on the panel, because they are themselves relating to this very field, so they understand what is happening. But the common man in the society, mostly women who are not fortunate for most of us, who can reach out to the best treatment or whatever they want to. But listening to the interview by that lady, it was again something that we have to understand, that even those people who can afford go through so much trauma. So this is something that we need to understand. I will just confine myself on two things. Number one, because my introduction was as the president of Family Planning Association of Pakistan. I did that for 3 tenures. Now I'm the vice president. So, but I have the information, whatever is available with us. And it is a few organizations which actually are doing something to a very limited, thing. So I must tell you that Family Planning Association of Pakistan is doing screening for cervical cancer through VIA. We have been doing this. And then if we find some changes, we give cryosurgery services at our hospitals wherever they are available. So we do this service as well. We are also screening through PAP smear at FHH. That they are FHH family health hospitals all over Pakistan. And all doctors and staffs are trained in this. So this is something good to know. We have developed a manual for cervical cancer screening by Dr. Noreen Zafar. She is our consultant. And it has been reviewed and approved by UK-based gynecologists. Now, these are the things that I wanted to share with you, that we are doing it. But of course, this is just a limited sphere that we work. We cannot actually take the responsibility what government should be doing, what the public sector should be doing. It is the small things that we are moving on. But, you know, I was just thinking, listening to everyone, that whosoever is doing something in the society is doing it at his or her best. But I think Pakistan or the health sector or the public sector, in health public sector, we have actually not tried to fix our priorities. What should be our priorities? I don't think that even today we realize this. And we keep forgetting the society cannot be working or developed society. We cannot call ourselves a developed society unless you take care of your women right from the beginning. And we have forgotten all these things. And now, even nowadays, it is not the health of women which is important for anyone. But we are just putting just few things here and there. What I am going to suggest here, that government, when I say government, is the Pakistan government at the federal level, as well as all the provincial level. Because now after 18th Amendment, health is, of course, it was already, and it is today even, is the responsibility of the governments, various governments. I think they should be taking the responsibility of actually addressing this very important cancer, which is everybody is saying it is curable. Now, I mean, when it is curable, it is diagnosed. It can be diagnosed if you apply correct methods at the early stages. So I think that one thing which can save hundreds and thousands of lives of women before entering into any dangerous state, I think there should be the vaccine, which as we all are talking about, and which is, you told us that it is available. I thought it was not available, but it is available, but of course it is very costly, and not everybody is going to, bear the cost. So I think there should be vaccination in the public sector. And if not, then they should enter into their PC1 when they are making the budget, put it into their PC1 and have these vaccines available to women, whosoever desires this. And of course, this is how we have to, should get the HPV virus should be addressed with this. And since you are having Dr. Azra for the final remarks, or Dr. Talib Lashari, I hope they are listening to it. It is not difficult for them to do this. If they are serious, I will be addressing your organization that I think you should make a committee who should go personally meet these health ministers at all the levels, all the provinces, and maybe at the federal level, and put your demands with them. This is one thing that you can do. I really don't know if you need any legislation for this. Then for that, advocacy is required. That can also be done. You can discuss it at your level. And 2-3 things, that the advocacy at all levels, and basically with the government. And believe me, I think even the people, educated people like us, may not be aware what they are going through. They are not aware what disease is this, and they are not aware that this can be dealt or treated by a vaccine. So these are my recommendations for today.
Thank you, Mrs. Mahtab Rashdi. You are always very eloquent, and you've raised very important points, and we will seek your help because we are already planning to do this and meet the ministers very soon. What I will emphasize here is that the vaccine is cheap. It's less than 5,000 rupees, and the disease is preventable in nearly 100% of cases. It is over 93% preventable so far with just vaccination. So अगर आप कुछ और भी नहीं कर रहे, सिर्फ vaccination कर रहे हैं, you are preventing 93% of the cervical cancers, which we are not doing, which is far cheaper than going towards curative treatment.
But Dr. Sadia, sorry I'm intervening, but even 5,000 for a poor family is too much. So
yes, this is
for us it is
absolutely
cheap.
right. That's
Yes.
why I showed the slide that the women who need the vaccine most are the poor women.
Poor
The
women.
rich ones, yes, the poor women in the villages with bichariyan wo late present karti hain, too late. So we need the free vaccine, and the sad thing is we get the other vaccines in the EPI schedule, they are free. And similarly, Pakistan, if it applies to Gavi funding, international donor funding, we can get this vaccine as well for free for our public at least. So we should be doing that. Now, thank you so much. And we will be asking for your help.
Thank you. Anytime. Anytime.
Yes. So I will address Mrs. Nurul Huda Shah, who is known to, most women like us in Pakistan for her amazing writing, her poetry, and for standing up for women's rights. I don't know if she's still here. She has been listening to us very patiently. Noor, can you please put on your... she was having some connectivity issues, so I think we may have lost her. Maybe she'll rejoin. So I was going to ask her about what she can do for this. So I will move on to our next panelist, Dr. Fauzia Asad from Jepaigo. I don't see her either.
Yeah, Assalamu alaikum everyone.
Okay,
Sadia,
thank you. Thank you.
For giving Jepaigo this opportunity to share our experiences and our work with all of you at this point in time. As you know that Pakistan has a population of 60 million ages between like 15 years and more women who are at risk of cervical cancer. Unfortunately, as you have all discussed, that we don't have any central registry system around this subject. So whatever the data is available, which is very patchy, honestly, but with reference to HPV Center report, more than 5,000 women suffers from cervical cancer in Pakistan annually. And out of 5,000, more than 5,000, more than 3,000 die just because they don't get vaccinated, they never got screened, or neither gets any sort of treatment in the country. So there is an issue of lack of awareness, lack of access to the facilities, and lack of knowledge at every sphere of this universe. So I think Jepaigo, being an affiliate of Johns Hopkins University and in collaboration with International Vaccine Access Center, which is known as IVAC, is another branch of Johns Hopkins. We are doing a landscaping exercise. We have already completed it with doing some in-depth interviews and key informant things, and some analysis work across the country with the support of the national EPI and their provincial chapters. This exercise has been done with the support of Gavi Alliance. And in today's platform, I really would like to share the current state of affairs. Already some of the points are well discussed at this forum, which are already coming out of the finding as a part of the finding of the landscaping exercise. And the very next step is that the drafting of the roadmap in consultation of all the stakeholders who are already working and doing some amount of work on cervical cancer. So one of the findings which has come up is the level of the knowledge among the communities, not only the communities, but unfortunately the providers who need to be sensitized first and advocate and talk about first on this subject. And then immunization, if you see our national immunization program, it is mainly focused around infants and young children, and very less focus is on women's health. Only, I mean, the TT vaccination is the one which a pregnant woman gets in the complete immunization program. So once we see that cervical cancer is a chronic disease, so there is a missing link between prevention and this chronic disease subject itself. Then as a stakeholder, if you see, then there is a limited discussion which goes on between different stakeholders, whether if you talk about the public sector or the private sector even. And unfortunately, that's not a so much priority area seen among the donor community as well, because we are not talking about it. We are not self-realizing the gravity of the situation. Pakistan is ranked number 3 in cervical cancer. It's so horrible state of affairs. I don't know why we are waiting for what we are unable to take further steps to address this thing. God forbid if it comes to number 1. We talk about too much about the breast cancer. Ideally, we should talk about the cancers of Pakistani women and not celebrate a week or a day for the breast cancer only, make it a complete week for all the cancers with which a Pakistani women can suffer or suffering from. But the good thing is that that we have seen a ray of hope based on the prior experience of introduction of different vaccines in Pakistan. Pakistan has been seen as early adopters of various other vaccines, like if you see the case of pentavalent, polio vaccination, typhoid vaccine, even rotavirus vaccine. So the government got convinced and made it part of the complete immunization program. So some of the building blocks which we have to work together as different set of the society are to establish some evidence around the disease burden itself, and then how much is the vaccine acceptability among different type of population, and what can be the strategies about these the community mobilization itself. And then advocacy. It's not only advocacy among the communities which matters, but first of all, as Dr. Rehana well said, that we still have to sensitize ourselves as providers, as different society experts, to really acknowledge the fact that this is the need of the time, and we have to start discussing and doing and implementing and generating best evidences in the context of our own country to make our case convinced. Then financial affordability is another thing, because as you are saying that it's available, and like for the people like us or upper quintile segment of the society, 5,000 means a lot. But for a rural women, for our underserved population, it will be a big amount. So definitely PC1 is one of the answers where we can do a bulk purchase and can do some sort of, subsidized procurement. All these things are available, and these things keep going on within the system. Then public-private partnership would be important. I have seen a province of Sindh very proactive and led.
Sorry, Dr. Fauzia, Dr. Talib has to leave very quickly. So,
Okay. This is my last point, Dr. Sadia.
okay, that we have to take Dr. Talib's comment.
Okay, so I think Sindh has already demonstrated introduction of evidence-based and convincing practices in Sindh, like post-pregnancy family planning and introduction of DMPSC, 3 months contraceptive injection as a subcutaneous. So I think cervical cancer is another thing which can be introduced with further advocacy. That's all from my end. Thank you very much.
Thank you very much. Thank you very much. Our well, our chief guest really is Dr. Talib, who has been patiently listening to our presentations. Dr. Talib, I would like you to sum up the meeting and the way forward that you see coming from the government of Sindh.
Thank you, Dr. Sadia Pal. At the very outset, I must thank you and appreciate the efforts of SOGP, NCMNH, and AMAN for bringing this very critical public health issue on the radar, on the radar of policy making, on the radar of programs and the projects. So I think this is very important from that perspective. Secondly, as you know, I'm mostly focusing on, and my mandate is on family planning. Though it also expands to reproductive health, but mainly I support to the minister on family planning affairs. But being a public health professional, I can say that this is a very important area where we must focus. Preventable diseases have long been neglected, and despite having a lot of evidence that 90% of the issues in the health relate to primary health care and public health issues which are preventable. And I can see that there has been lately refocusing and reprioritizing, whereby the governments are now, not only in Sindh but everywhere in other provinces as well, they are trying to focus on primary health care and preventable diseases. And thanks to the whole professional bodies and the development partners, and definitely the providers have also played a role into it. So I think these are some of the starting points that I wanted to share. In the public sector in Sindh, we don't have mechanisms, as I'm told by Department of Health, that we don't have very structured program on screening or on awareness, or definitely not on vaccination as well. So I think this can be a starting point. Today's session can be starting point. But let me to add that at the tertiary care level, at the OPDs of gynae, there is some sort of investigative approaches there, like pap smear, and even some history taking is taking place. So what is needed is to take into account the data that is being generated at the tertiary care level, but we need to integrate that at secondary level as well. So I would suggest an advocacy approach, maybe led by SOGP and other partners, on three things. One is awareness, because awareness, as I have heard from so many speakers here, that they wanted awareness within the providers as well. That can be also critical, because providers are not that much aware about this very challenging issue in the public health. Second thing could be screening, focus of advocacy on screening. How this could be done? This would also be done through creating synergies with the education department. Education department at the public sector level and at the private sector level. And thirdly, the focus of advocacy could be on vaccination. I mean, it also includes how to procure, how to, as you and Madam Mehtab Rashdi said, that poor patients can't afford rupees 5,000. So how to subsidize, how to provide incentives for them. So I think these three areas, awareness, screening, and vaccination, these come out very clearly from this session. And for that, we need an advocacy at policy level, advocacy or awareness at provider level, making synergies with the education department. We know that our immunization program focuses up to second year of the child, and we don't have the programs in the rest of the age groups except for TT vaccination for the pregnant women. So I think this could be an opportunity to create some public-private partnerships as well, because private sector is in a more capacity or in a more position to support some sort of and I would suggest some sort of pilot starting from some hospitals for that public-private partnership can be established. My last 2 points would be on one thing which is about population welfare department in Sindh province especially. Population welfare department has 74 reproductive health service centers. The mandate of reproductive health center is not only family planning, but reproductive health as well. So I think let me think, and I'll discuss within the department that how we can initiate some sort of piloting or some sort of support in terms of screening and in terms of pap smear test, if that is possible, in the population welfare department facilities. But I can't say final word here, but I will definitely look into it. I'll discuss, and then maybe we can share it with the Honorable Minister that how these population welfare department centers can include into their, although it's a very cumbersome task. So for that, we need to take into account the issues of providers and the service delivery managers as well. And lastly is the data. I think SOGP can start some sort of data gathering from different tertiary care hospitals and sharing at some policy level forums, so that we could have some sort of case for a policy frameworks. So data will be, I think, very helpful in this regard. So with these words, I think lots of points were made in this session by our esteemed professors from across the country, and they have a lot of experience with them, so that all SOGP can sum up into a report, and that report can be shared within the public sector for any next steps. So thank you so much for giving me this opportunity.
Thank you so much, Dr. Taleb, for being there, and you are there for all our very important meetings related to health of women. And not just this, but family planning. We know the excellent work that you and your team is doing in CIP. So thank you, and we hope to take it forward with you and our Honorable Minister, and at the federal level as well. Once we have, as I pointed out earlier, Sindh has taken a lead in many women's issues, including early child marriage, which helps this cause as well, actually, that, early marriage and all that. And we hope that we can have this vaccine in our EPI schedule in the near future. Thank you so much. And I will request Professor Haleema.
What I can add, Dr. Sadia,
yes,
that we are in process of finalizing the marital counseling bill.
Yes, yes.
And the nikah registration. So this point can also be added into the bill, so that when a couple goes for counseling at a facility, they will, besides family planning, they will also get information on cervical cancer, breast cancer, and other related public health issues.
Thank you. Thank you so much. So I will request Professor Haleema to give her vote of thanks and conclude the session.
Thank you very much, Dr. Sadia. So I take this opportunity to formally thank our President, Professor Razia Korejo, our Chairperson for Gynae Cancers, Dr. Sadia Ahsan, who developed the idea and concept of this meeting and invited all other partner organizations. I'm really grateful to our partners, Association of Mothers and Newborns, NCMNH, Pakistan Pediatric Association, other healthcare agencies like JPIGO, WHO. I'm really grateful to NGOs like FPAP, and we would like to include others and the professional organizations like PMA to hold hands for this very important initiative of starting nationwide screening awareness, as well as developing strategies to procure and give vaccinations to all women of the age when it's really needed. My sincere thanks to Dr. Talib Lashari and Ministry of Health, Government of Sindh, for sending him here and being with us and bringing in his wisdom to definitely chalk out some plans to start from somewhere. All the gynecologists and senior members of SOGP who joined us, all members who joined us on Facebook page, our secretariat staff, our sponsors, the SAMI Pharmaceutical. If I missed on any name, please spare me for that. The oncology colleagues from Atomic Energy Center and other organizations, consultants from Aga Khan and Shaukat Khanam Hospital, the public sector hospitals who are dealing with these burdens of disease with us, the public sector hospitals, and the Gynae Oncology Committee of SOGP. I'm really grateful to Dr. Shahida Zaidi, a very senior member of SOGP, AMAN, and NCMNH, for being with us at all the times. Dr. Azra and her team from NCMNH and AMAN. Let's hope, let's wish that this initiative which we started, it really kickstart now, and we really see a day when we pick up early disease, we screen disease, and we are able to prevent it at an early stage and treat it when it is less expensive and less painful. Thank you again. Assalamu alaikum.